So, yeah. Good evening, students. I'm Dr. Sarath Balaji, your pediatrics faculty for PW. Right. Let me start my discussion on paper 2. Paper 1 was discussed yesterday. You want some discussion on paper 1 also? Let me continue. So, let us finish the first paper 2. Right. 2-year old, and I'll be looking into the chat box today so that if there are some issues with respect to the stem of the question or the choices of the questions, we can correct it and you can ask your doubts directly. Right. 2-year old vital stable ECG is showing paroxysmal supraventricular tachycardia. What is the next step? Is it cardioversion, adenosine 0.1 mg per kg or adenosine 0.2 mg per kg? What is the fourth option? Is it amiodarone? Is it amiodarone? Fourth option. So what is the answer? Can anyone tell me? Or a majority of you would be answering for adenosine. We all know that. So is it zero point 0.1 mg per kg or 0.2 mg per kg? So I'll be looking into the chat box. Is it zero point 0.1 or 0.2 mg per kg? The answer is very simple. Whenever you have a narrow complex tachycardia and you need to see whether the child is stable or not. Stable means whether the BP is normal or not. If the child is having normal BP along with without any symptoms of a shock, then you can try adenosine. So adenosine will be the drug of choice in any cases of narrow complex paroxysmal supraventricular tachycardia without any P waves. So what is the dose of adenosine? Adenosine can be given 2 times. The first dosage is 0.1 mg per kg. The second, if 0.1 mg per kg rapid IV push is not working, then you can go for 0.2 mg per kg. So the question probably is what is the first step? The first step is adenosine 0.1 mg per kg. Okay, rapid IV push. If 0.1 mg per kg doesn't work, then you need to go for 0.2 mg per kg. The answer is 0.1 mg per kg. And if it doesn't work, you need to go for 0.2. If it doesn't work, you can go for amiodarone, otherwise known as cardarone. What is the role of cardioversion, direct DC cardioversion? The role of direct DC cardioversion in case of paroxysmal supraventricular tachycardia in unstable patient. What do you mean by unstable patient? When their BP is low or when the child is brought with shock, then you can consider cardioversion 0.5 to 1 joule per kilogram. Okay, right. So the answer for this question is adenosine 0.1 mg per kg. Do you have any doubts in this? Waiting saline flush. Oh, okay. Yes, IV adenosine 0.1 mg per kg followed by saline flush. It is not saline flush alone. It is not at all saline flush alone. Okay, not in shock. So not in shock means the answer is adenosine 0.1 mg per kg followed by rapid IV saline push. If it doesn't work, then adenosine 0.2 mg per kg. Right. So the answer is adenosine 0.1 mg per kg. If you have any doubts with respect to the options or the step, you can post in the chat box. Let me looking into the chat box regarding further queries with regard to this question. Is it okay? Okay, Nimra. Right. Pulse is palpable. So what does it mean? In pediatrics, we often look for dorsalis pedis pulse. Dorsalis pedis pulse is the marker for shock. When we don't find any dorsalis pedis, then we consider the child is said to be in shock. Okay, right. Then let's go for the second question. 5-year-old unimmunized with diphtheria. Brother, 2-year-old immunized. What is the prophylaxis? Is the stem correct? Is it the stem correct? What is the prophylaxis? Diphtheria vaccine booster single dose, erythromycin, diphtheria toxoid full course, nothing is required. Okay, I would like to know whether the stem of the question is correct or not. One child is brought with the diphtheria and unimmunized child. Second child, brother 2-year-old immunized. Brother is stable without any sign. So what is the answer for this? Erythromycin, diphtheria toxoid, full dose. What is the answer? Penicillin instead of erythromycin for contact. So remember, single dose of benzathine penicillin or a single dose of erythromycin is required for all contacts. Single dose should be given. Both penicillin and erythromycin, if it is given, both are correct. Yeah, no problem. Single dose benzathine penicillin is enough. Yes, do you give any vaccine for the child? There is no need for any vaccine, particularly if the child had received 4 doses at 6 weeks, 10 weeks, 14 weeks, as well as at 15th to 18th month. If it is a 2-year-old child and fully immunized means 6 weeks, 10 weeks, 14 weeks, and at 15 to 18 months, if the child had received the vaccine means, then there is no need for any booster dosage. If the child is around 6 years old and if the child had not received a vaccine at 4.5 years, then you need to give that vaccine at 4.5 years, that DPT, capital D, capital P and capital T vaccine at 4.5 years. But after 5 years, as per the recommendation, TD vaccine at 10 years. But if the contact had received any dose of booster vaccine before 5 years from now means, then you can give a single dose of booster TD vaccine, right? If the contact doesn't received any kind of vaccination primary series, then you need to restart the series freshly. So what is the 2-year-old with the SVT? Okay, again you are going back. And bilateral Krebs adenosine can cause bronchospasm. Okay, so what is the answer for this question? Completely immunized was mentioned. So completely immunized was mentioned means, even then you need to give erythromycin, single dose erythromycin or single dose penicillin to avoid spread from the child to the contact. Nothing is required. So what will be the answer? Is it nothing is required or a single dose of erythromycin? Nothing is required or single dose of erythromycin? Any contact, irrespective of immunization status, should receive single dose of erythromycin or yes? Oh, no, no problem. If erythromycin is not there and instead if penicillin was given, you can opt for that. All contacts, all, okay, right. Brother is fully immunized. Yes. How do you treat the brother? That is the question, na? No problem. If erythromycin is not there and penicillin is there, then you can opt for penicillin. You can opt for penicillin. All contacts, I repeat, even standard textbooks like Nelson, sure, it tells that irrespective of the immunization status, a single dose of penicillin or erythromycin should be given. As far as the vaccine is concerned, I don't think you need to give any booster dose because the child had received all primary series. Up to 2 years of age, the child is fully immunized. Right. Going for the next question. Lowest compartment, which vaccine is kept? Lowest compartment, which vaccine is kept? Maybe there are some crossovers between pediatrics or with respect to SPM. What about the stem of this question? Lowest compartment, which vaccine is kept? Is it pentavalent, DPT, hepatitis B, OPV? What is the answer? Lowest compartment. What happened to you? OPV. Repeat question, OPV. Lowest compartment means what? Would like to know what do you mean by the lowest image of ILR? Okay. Lowest compartment with respect to ILR. Okay, very good. Lowest compartment with respect to ILR means OPV, but lowest compartment with respect to refrigerator means what will be the answer? Image of heat sensitive. Very good. Lowest compartment is OPV. Fine. But I hope it is the image of ILR and not the image of refrigerator. If it is the image of refrigerator, then the lowest compartment you can keep varicella, hepatitis B under diluents. But here the question is with respect to ice-lined refrigerator, and the lowest compartment you need to give OPV vaccine. Right. Correct. So is this the image that you had with respect to pediatrics? Yeah, ILR is mentioned, so OPV is the correct answer. So is this the image that was given? And I would like to know the stem of the question. Is there any question regarding TGA? Is there any question regarding Pompous? Okay, so what is the question regarding Pompous? What is the question regarding Pompous? So is this the question? Floppy infant, dilated cardiomyopathy and hypoglycemia. Okay, is this the question? Floppy infant, dilated cardiomyopathy and hypoglycemia. Yes. So when you have a floppy infant, dilated cardiomyopathy, along with hepatomegaly with hypoglycemia, more in favor of a Pompey's disease. Because in 𝐒𝐿𝐴𝐻𝐾𝐝 disease, you won't get a floppy infant, but you can get hypoglycemia, hepatomegaly, and rarely cardiomyopathy. Epstein's anomaly is characterized by very large heart. The largest heart in a newborn usually you get in two conditions. One is Pompey's disease, another is Epstein's anomaly. But both 𝐒𝐿𝐴𝐻𝐾 and Epstein's are not associated with Epstein's anomaly is not associated with the floppy infant, and 𝐒𝐿𝐴𝐻𝐾 disease is also not associated with the floppy infant. So the answer is Pompey's. So is there any question regarding TGA? Is there any question? When you say box-shaped heart, then your choice should be Epstein's anomaly if question was not framed properly. If the question contains hypoglycemia under floppy infant, then it must be Pompey's disease unless otherwise proved. When you said box-shaped heart, it is more in favor of, because Sahil has told it is box shape. Box shaped heart means Epstein's anomaly. But as far as this question is concerned, Pompey's disease is the answer. Okay, right. So what other questions? Right. Is there any question? Two different questions. Is there any question with respect to TGA? Is there any question with respect to transposition of great arteries? Is there any question with respect to, because some had given me question regarding TGA. Is it so? Is it so? Any question regarding TGA? Cardiomegaly was there? Okay, no questions regarding TGA. Then leave it. Leave it. Okay, is this question framed properly, or if you want to ask any questions, okay. Look at this. X-ray features mimicking scurvy. Which nutrient deficiency? Is there any question asked with respect to these teams? TGA, neonate live till. Okay, is this question asked? See, remember, there are two types of transposition of great arteries. One is TGA with the intact septum, another is TGA with the ventricular septal defect. TGA with intact septum, if you don't treat, it will die about in the third or fourth day. TGA with VST will live because there is a defect and there is a place for a mixture of deoxygenated and oxygenated blood. So is there any question? Hair pigmentation, X-ray of scurvy. Okay, X-ray of scurvy. Okay, but what is the question frame? Is it related to direct question related to vitamin C, or there is an indirect question? Can anyone help me in framing the question and choices? No Q related to TGA. Then leave it then. Patient with anemia. Yeah, I got it. Nimra, I got it. Got it, Nimra. Okay, very good. Patient with anemia, neutropenia, depigmented hair and skin image of line of Frankel in X-ray. Okay, yes, that should be the question. So what is the answer for this one? When you have an anemia, neutropenia along with the depigmented hair and skin, depigmented hair and skin with the image resembling Frankel. Can anyone tell me? Yes, very good. Thank you. This is more than enough. This is more than enough. So what is the answer for this question? You have anemia, you have neutropenia, you have skin and hair depigmentation, and something resembling white line of Frenkel, marked copper. How many of you Wimberger sign was seen? So what? Though that is okay. So what is the micronutrient deficiency that resembles your vitamin C deficiency? Very good, very good, very good. No, it is not fluorosis. It is not at all fluorosis. One of my student also had marked fluorosis. Definitely, it is not fluorosis. No, no, not at all, not at all. Anemia, neutropenia, depigmentation, radiological changes resembling scurvy unless otherwise proved, it is copper deficiency. You do not have. So even when you say fluorosis, it is definitely not the answer. Fluorosis is wrong. Copper deficiency is the correct answer. Very good. It doesn't mean that you need to have a 𝐒𝐿𝐾𝐝 hair disease to have features of this copper deficiency. It is just nutrient deficiency is copper deficiency. Right. No, it is copper deficiency. It is a clear-cut, straightforward question. Both you can refer Nielsen or you can refer OP Guy. Skin pigment depigmentation, features of scurvy, anemia, neutropenia is classical feature of copper deficiency. Yes, it is copper. Don't worry, it is copper. It is not at all fluorosis. Right. Okay. Then what are all the question? Is there any question about congenital diaphragmatic hernia? Is there any? Okay. Can anyone help me in framing the question? Okay, Nimra, thanks for framing the question and framing the question properly and posting it. Congenital diaphragm. What is that question related to congenital diaphragmatic hernia? Is it related to most common type of congenital diaphragmatic hernia? Yes. Most common site is left to posterolateral. That is what is that? Bochtalak hernia, and it is followed by retrosternal hernia, or otherwise known as Margagnion's hernia. Most common site is left posterolateral. Okay, due to defect in pleuroperitoneal membrane. Right. Yes, posterolateral, right. Okay, these are all about yesterday question. Is there any question with respect to paper 2? Is there any question with respect to paper 2? I'll be happy to answer and clarify if you post in. Are there any further question which is not discussed in paper 2? Box-shaped heart, which is the most common? Congenital rubella syndrome. Ravi Shashwant, what is that question with respect to congenital rubella syndrome? Can you frame it? What is that with respect to congenital rubella syndrome, or any other questions that was left? I am ready to answer. Okay, a picture of blueberry muffin lesion was given. Is it related to congenital rubella syndrome? That is what you no question on paper 2. Okay. So if you don't have further questions to ask, let me finish my session. If you have any questions, let me wait for about a minute or two. No issues. So this is exclusively with regard to no questions then. Okay, this is exclusively with regard to paper 2, not paper 1. A rapid revision on paper 1. Okay, right. This is okay. So yesterday one question was asked. So this is twin-step deformity. Whenever you have normal phosphorus, unless otherwise proved, it is hypophosphatemic rickets. Normal phosphorus means it is hypophosphatemic rickets unless otherwise proved. Okay, and what about this question? Yesterday question, paper 1. Probably this is a case of 𝐒𝐿. Congenital cystic adenomatoid malformation or congenital cystic pulmonary malformation, when you have a bulbous lesion and the mediastinal is pushing to the opposite side. Prasad, what is that? If the membrane toxoid can be answered, I could not understand what you are asking. So this, this is bladder extrophy. And investigation of choice for posterior urethral wall is not ultrasound, it is vesicocystourethrogram to find out the dilated posterior urethra. And you all know this is congenital hypertrophic pyloric stenosis. Okay, whatever it is, membrane in tonsil. So, Egon side appearance, someone is giving MCU. Right. So, this is Camon's curve. Someone said it was asked yesterday with respect to growth chart. Cholera toxoid in question paper 2. Whether it was discussed or not, if it is not discussed, can you post me the exact question? Let me try to. Epstein's on RJ squad, Epstein's anomaly. See, whenever you have a. So, what is the manifestation of an Epstein's anomaly? Epstein's anomaly, the child will be having intermittent cyanosis and the largest heart that you can ever see, even compared to Pompey's disease. Whenever your image contains the largest heart without showing any lung, it must be Epstein's, but I don't know the exact question. Right? Then ADHD, one question was asked yesterday. If it is a drug of choice with the cardiac illness means atomoxetin, without cardiac illness means methylphenidate. Pompey's means yes, okay, leave it then. Cleft lip, when it was operated, for cleft lip should be operated by 3 months and cleft palate should be operated before first birthday. That's all. Okay, and yesterday with regard to this is definitely a case of acute lymphatic leukemia. When you have more than 2 cell line involvement along with hepatosplenomegaly and particularly between 1 to 2 years, it is a case of acute lymphatic leukemia, and the treatment of choice should be vincristine or prednisolone or any other combination apart from that if it contains asparaginase or downomycin. These are all the 4 drugs are initially used in the remission induction. Central adrenal insufficiency. Yesterday, one question asked on paper 1. It is the drug of choice is hydrocortisone alone. Right? Best investigation of Wilson is hepatic copper. Best investigation. Right? Anemia, hepatosplenomegaly, bone pain, crumpled tissue paper appearance. You all know this is such an easy question. Glucocerebrosidase. Villus atrophy, crypt hyperplasia must be due to celiac disease. And again, when you have a failure to thrive along with, as I told you already, when you have chronic diarrhea after 2 years of age, the most common cause is celiac disease. Chronic diarrhea less than 2 years, most common cause is cow milk protein intolerance. Which of the following is harmful? We don't bath immediately after birth. The other things can be followed. Okay, conjunctival suffusion, hypokalemia, retroorbital bone pain, particularly if it is during associated with the rice paddy feel something, it can be leptospirosis. Otherwise, dengue can also be the answer. Niacin deficiency, 2 questions were there. So, what is that question? Okay, no problem. This question probably it is leptospirosis because we have been seeing a surge of leptospirosis right now in the past few weeks, right? So I will be happy if you post proper questions along with the proper answer. We can have a proper session with full STEM question and full correct choices. Thanks for your patient listening. Bye bye. Next, investigation of choice in dengue. What is that? Eating celiac wheat related to that. Homeless person mainly eating maize is niacin deficiency. Okay, dengue investigation, first 3 days the dengue investigation is NS1. 3 to 4 to 7 days then you need to do serology like IgM, but the treatment is mainly based on hematocrit and not the platelet count. Treatment is mainly based on hematocrit and not platelet count in case of dengue. So, with this, I am finishing my session. Thanks for your patient listening. Bye bye. If you have some question, you can post it. I will be answering in your session in comment box even after